Hello everyone. In this video, we will simplify the Piver-Rutledge Smith classification of radical hysterectomy, which is a landmark system that categorizes the radical hysterectomy, which is a treatment option for cervical cancer in the surgery part. And this is based on the extent of tissue resection. Let's understand each type in a simple and exam-oriented manner. So the Piver-Rutledge Smith classification system has five types of hysterectomies. Coming to type 1 hysterectomy. Type 1. Another name of type 1 hysterectomy is extrafacial. So this is also known as extrafacial hysterectomy. Here the vagina is minimally removed. Bladder is partially mobilized, ureter is not mobilized, uterine artery is ligated at the level of the uterus, parametrium is resected at uterus, and the uterosacral ligament is transected at the uterus. So see the diagram on the left side of the screen. So the center is shown as the cervix, and when the tissue is removed just around the uterus and in closely to the uterus, then this is a stage or type 1 of radical hysterectomy. This type 1 of radical hysterectomy, also known as the extrafacial hysterectomy, it has another name also, which is simple hysterectomy. So this is the simple hysterectomy that we do in our routine practice. Now coming to type 2 hysterectomy. Type 2 hysterectomy is modified radical hysterectomy. This is also known as Wertheim's hysterectomy. So this is the Wertheim surgery. In this, what we remove, that the upper 1 to 2 centimeter of the vagina removed. So vagina is removed in 1 to 2 centimeter upper part. The bladder is partially mobilized, just like the extrafacial hysterectomy. Ureter is unhooked in a parametrial tunnel, unroofing is done, and uterine artery is ligated medial to the ureter. So uterine artery is also ligated medial to the ureter. Now coming to the parametrium. Medial to the ureter, parametrium is also removed. So the second part is in the diagram on the left. The second part is the radical hysterectomy type 2, where there is removal of half of the parametrium. And another name for this hysterectomy is modified radical hysterectomy, or type 2, or the Wertheim's hysterectomy. The uterosacral ligament is also cut at the midpoint of the ligament. Now the third hysterectomy is type 3. Another name of type 3 hysterectomy is radical hysterectomy. So here extensive surgery is done. So this is radical hysterectomy, also known as the Meeks hysterectomy. And here the upper 1/3 or 2/3 of vagina is removed, along with complete mobilization of the bladder. Bladder is completely separated from the uterus. The ureter is completely dissected until the entry into the bladder. So here this is type 3 hysterectomy, where there is extensive resection of the parametrium, and the uterine artery is ligated at the origin from the internal iliac artery. Resected at the level of the adrenal, at the level of the adnexa, parametrium is so much removed, and the uterosacral is also transected distal to its attachment to the rectum. So this is type 3 radical or the Meeks hysterectomy. Now the fourth is extended radical hysterectomy. So the fourth is extended radical hysterectomy, in which there is complete dissection of the ureter from the pubovesical ligament. Superior vesical artery, which supplies the bladder, is also sacrificed, and upper 2/4 of the vagina is removed. So the vagina is just like radical hysterectomy. Here the bladder is completely mobilized but not resected. So there is no resection of the bladder in type 4 hysterectomy or parametrium. So in type 3, as much as possible we try to remove the parametrium, but in type 4 all parametrium is removed. So here all parametrium is removed. Uterine artery is ligated at its origin at the superior vesical artery. So in type 3, uterine artery is ligated at the level of internal iliac artery, and in type 4 it is ligated near to the superior vesical artery. Parametrium just like that, and uterosacral ligament also like the previous one. Now there is type 5, which is known as the PEE. PEE is the pelvic exentration surgeries. So in pelvic exentration surgeries, the bladder mucosa is also resected. So here we also remove the bladder portion along with distal ureter, and rest is same like type 4 hysterectomy. So this is the Piver-Rutledge Smith classification. We can also depict this with the help of the diagram. So if you consider this the uterus, so this is the uterus, this is the cervix, and this is the vagina. So in Piver-Rutledge classification, if we remove the uterus along with the cervix as close as possible, this is type 1 or the simple hysterectomy. If upper part of vagina or upper 2 to centimeters of the vagina is removed, this is type 2, also known as the Wertheim's hysterectomy or the modified radical hysterectomy. If complete or minimal part of vagina is left and all the parametrial tissue is removed, then this is type 3 hysterectomy. If the ureter is removed at the level of the superior vesical artery and all paraurethral tissue is removed, completely mobilized bladder, then this is stage 4. And when there is also resection at the level of bladder and distal ureter is also removed, then this is type 5, also known as the pelvic exentration surgeries. Now there is also one classification system which is known as the Querleu-Morrow classification system, which is proposed in 2007. So in 2007, an interesting system known as the Querleu-Morrow classification system has been proposed, and we follow this classification system nowadays. Coming to this classification system, just wait. Yes, so in previous staging system we divided the types into type 1, type 2, type 3, type 4 and type 5. But in Querleu-Morrow classification system, we divide the radical hysterectomy into type A hysterectomy, type B hysterectomy, type C hysterectomy and type D hysterectomy. Coming to type A hysterectomy. So what happens in type A hysterectomy, that the basis of this system is the paracervix. Paracervix is the tissue that is present around the cervix. So if this is the uterus, this is the cervix and this is the vagina, so the tissue around the cervix is known as the paracervix. Just like parametrium around the uterus, the tissue around the cervix is known as paracervix. So in type A, what happens, that there is minimum resection of the paracervix. So here there is minimum resection of paracervix, and the paracervix is transected medial to the ureter but lateral to the cervix. Uterosacral vesico-uterine ligaments are not transected at a distance from the uterus. Vaginal resection generally minimum without removal of the paracolpos. So paracolpos is the part of parametrium which is around the vagina, and in this condition palpation or direct visualization without freeing from the bed. So ureter is not touched in this condition. So in type A, only this part is removed, that is the paracervix close to the cervical tissue. Now type B. So in type B, there is transection of the paracervix at the ureter. So if this is the uterus, this is the cervix, this is the paracervix part. So here ureter is traversing, and this is the pelvic side wall. So till the level of ureter, this part is removed. So this is type B, where is transition of the paracervix at ureter. तो हमें यहाँ पर ureter तक paracervix को निकालना है, ठीक है. Paracervix is transected at the level of ureteral tunnel. Partial resection of the here the uterosacral and the vesico-uterine ligaments are also cut in the mid. There is no restriction of the caudal neural component of the paracervix, and here in the previous condition there is minimum resection of the vagina, but in type B hysterectomy the vaginal resection is at least 10 mm. So here we have to excise the vaginal part also, but the resection is just 10 mm. And there is unroofing and unrolling of the ureter also. Now this type B hysterectomy is further divided into two parts. And what are those parts? B1 and B2. So these divisions are based on the involvement of the lymph nodes. So if there is no lymph nodes involvement, then this is type B1 hysterectomy, and if the lymph nodes are involved along with the structures that are involved that are resected above, so if there is removal of the lateral lymph nodes, which are the pelvic lymph nodes, so here pelvic lymph nodes is also dissected. Now type C radical hysterectomy according to Querleu Morrow classification. So in this type C hysterectomy, there is transition of the paracervix junction with internal iliac vascular system. So here there is resection of internal iliac vascular system also. So the transition of the uterosacral ligament at the rectum. So this is just like your radical hysterectomy, where there is transection of the uterosacral ligament at the rectum, transection of the vesico-uterine ligaments at the bladder, and here the vagina is removed 15 to 20 mm. And in last two, type C and type D, both these condition ureter is completely mobilized. Now 3C is further divided into C1 and C2. In C2 there is autonomic nerve sparing, while when there is no preservation of the autonomic nerves, then this is type C2. So this is IMCQ question, that in which type of radical hysterectomy according to Querleu Morrow classification there is preservation of autonomic nerves. So the stage is type C1. This is type C radical hysterectomy. Now type D radical hysterectomy. So D is divided into D1 and D2, and another name for this is LEER. LEER means laterally extended endopelvic resection, and this terminology was described by Hockel. So when the resection of the paracervix at the pelvic side wall extends from the internal iliac system, so there is resection of the paracervix along with the internal iliac system and exposing the roots of the sciatic nerve. And when there is also resection of the hypogastric vessels plus adjacent facial and muscular extractions, then this is known as LEER. Mainly LEER is for type D2. So the resection of the entire paracervix at the pelvic side walls together with the hypogastric vessels exposing the roots of the sciatic nerve corresponds to Pal-Falvey's Angard laterally extended parametrectomy. And type D2 is when type D1 plus resection of the entire paracervix with hypogastric vessels and the facial and muscular structures known as laterally extended endopelvic resection. Now there are certain levels of lymph node dissection in cervical cancer. So if we make a diagram of the vessels that are possibly involved, so this is the diagram. just wait. Yes, so this is your aorta. Okay, this aorta is divided into two trunks, and these two trunks are the common iliac arteries, CIA. So this is aorta. These are the common iliac arteries, and these common iliac arteries are further divided into the external iliac artery and the internal iliac artery system. Just same is also here. So this is the external iliac artery, and this is external iliac artery, and this one is internal iliac artery. Now the levels are divided based on the lymph nodes possible. So we have to start from below upwards. So if the lymph nodes are below the division of the common iliac arteries, this is known as level 1. If the division is at the bifurcation of the aorta into iliac arteries, into common iliac arteries, this is level 2. If the division is at the level of just below the inferior mesenteric artery, so this is the inferior mesenteric artery, this is the right renal artery, this is the left renal artery. So this is 3, and above the inferior mesenteric artery, that is just below the infrarenal area, this is type 4. So the levels are level 1, level 2, level 3 and level 4. Level 1, internal and external iliac lymph nodes are present. At the level of level 2, common iliac nodes, also known as the presacral nodes, are present. At the level 3, aortic inframesenteric nodes are possible, and just below the renal vessels, infrarenal nodes are present. So if we dissect only type 1, this is known as pelvic lymph node dissection, and above is the para-aortic lymph node dissection, which is divided into level 2, level 3 and level 4. Now coming to the management based on the stage for cervical cancer. So the management is dependent on the type or the stage of the disease. So we have already seen that stage 1 is divided into 1A, 1B, 1A1, 1A2, 1B1, 1B2 and 1B3. Just like this, stage 2 is 2A, which is 2A2 and 2A1 and 2A2, and stage 2B. 3 is divided into 3 and 4, which are the higher stages. So मोटा मोटा अगर बात करें तो जो भी स्टेजेस लेस देन 4 सेंटीमीटर इन साइज हैं, कौन कौन से स्टेजेस हैं जो 4 सेंटीमीटर से बड़ा साइज जिनमें टिश्यू का होता है या फिर ट्यूमर इन्वॉल्व जो होता है वो मोर देन 4 सेंटीमीटर होता है. दिस इज स्टेज 1B3, stage 2A2 and these stages. Okay, so the stages other than 1B3 and 2A2 are the stages which comes under early stage cervical cancer. Stage 1B3, 2A2, stage 2B, stage 3, these comes under, and 4A. So 4A and then 4B. So this is the metastatic disease. This one is metastatic. So here we have only palliative options, and the rest stages other than 1A1, 1A2, 1B2, 2A2, 2A1. So these stages are early stage cervical cancer, and the rest are known as the locally advanced cervical cancer, where radiotherapy is the only option. So surgery is only possible in early stage cervical cancer. And now come to what surgery do we offer. So in 1A1, so first we will deal with the stages one by one. So in 1A1 we have to look for LVSI also. So if there is LVSI absent and LVSI present, So the option is, if LVSI is absent in the stage of cervical cancer is 1A1, means the depth of invasion involved is less than 3 mm. So we can offer the patient cervical conization, okay, which is the treatment for pre-invasive cancers of the cervix. So here cervical conization can be done, or simple hysterectomy known as the extrafacial hysterectomy according to Piver-Rutledge Smith classification can be offered, or you can say type A hysterectomy according to Querleu Morrow classification. Now in stage 1A1 with LVSI, the option we have is modified radical hysterectomy. So one step ahead, here we offer the extrafacial hysterectomy and here modified radical hysterectomy. And along with that, pelvic lymph node dissection is also done. Another option we can offer, if modified radical hysterectomy is not preferred, then radical hysterectomy can also be done. Now in stage 1B1. So stage 1B, we divide the stage 1B according to early stage cervical cancer into 1B1, 1B2. So from stage 1B1, 1B2 and 2A1, where the size of the lesion is less than 4 cm. So here also what we offer, the radical hysterectomy, and along with that pelvic lymph node dissection should be done. Now for bulky tumors. What are the bulky tumors? If the size of the tumor is more than 4 cm. And what stages comes under bulky tumor? That is 1B3, 2A2, 2B, 3, 4A. So here the option is chemoradiation. Either we know that we do not give multimodality treatment, either we can offer the chemoradiation or the surgery. So here what surgery we can do? Pelvic exentration surgeries can be tried here. Now in stage 4, stage 4B mainly. So the treatment in stage 4 which has metastasized to the pelvic organs, other side pelvic organs like the bladder and bowel mucosa, as well as in stage 4B2 there is possibility of spread to the liver, lung, etc. So here pelvic palliative treatments like either radiotherapy or chemotherapy can be tried, and the supportive care, that is hospice care, can be offered to the patient. So this is the treatment of cervical cancer according to the staging systems.